Now we're going to talk about motilities. The eyes have 6 muscles that move them around. And if the proper way of thinking about how the eyes work is if you take your hands and you cross them, this is your right eye and this is your left eye. Because there's your nose is in the middle, and you actually have, for your right eye, you have this medial wall of muscle, of bone, and this temporal wall, and it is like this. So the right eye is surrounded by bones all around it, and there's orbital fat around there, and you have to understand how the anatomy of the eye works to know what you're supposed to be doing in checking someone's motilities. You want to say, can you look up, down, left, and right? Well, it's really more than that. So let's take a second and talk about these motilities. So here's the right eye, here's the left eye, and so they can go up, down, left or right, and right or left, and then it can actually go into these, up into the left and down into the right, and they can rotate a little bit as well, like a clock, back and forth. Let's talk just about the right eye. The right eye has the superior rectus muscle, and there's there's this collection place at the apex of the orbit where all these muscles kind of come together, and there's a little ring of attachments where they all kind of tether down there. So you have the superior rectus, the SR pulls the eye up, the inferior rectus pulls it down, the lateral rectus pulls the eye out, the medial rectus on this right eye pulls the eye in, and then you have the superior oblique, and much like your obliques on your chest here, you actually have a little on the wall here. You have a little sling called a trochlea. It's just a little horseshoe that this muscle comes in and goes around that, and then it attaches here. So it's going to pull the eye down and out, and it's going to rotate the eye that way. That's the superior oblique. So even though it starts here, the origin and the insertion, the apparent origin is over here at the trochlea, and there's a condition called Brown syndrome where the muscle, the trochlea, is screwed up and the eye gets caught in a little hitch there and it doesn't work well. But that's the superior oblique. And then you have the inferior oblique, which kind of comes in around this way and pulls the eye this way. So there's 2 ways to think about this. A number of ways to think about this is there's 3 cranial nerves that move, that the eyes are responsible. You have 12 cranial nerves, okay? And 3 of them go to the muscles of the eye. There's SO4, LR6, remainder 3. So the superior oblique muscle has the 4th cranial nerve in your brain that is assigned to making this thing do this. So you go, okay, there's 1 nerve, one of our 12 cranial nerves goes to 1 muscle. So if you screw up that cranial nerve by some reason, either at the power station where it is or the nerve fiber itself or something, then the eye won't go down and out. So if it won't go down and out, that means the other 5 muscles rule. The other 5 muscles are going to decide where that thing goes. And so you typically have an eye that's vertically out of alignment. So the SO4, there's LR6. LR is a lateral rectus, and that pulls the eye out. And so the number 1 reason you have a problem there, since it's on the side, is if you get whacked in the side of the head. So trauma is the number 1 reason you have a lateral rectus problem. So some kid comes in there playing baseball and a ball hits them in the side of the head, their eye won't go out. So if your eye won't go out, that means that all the other 5 muscles are going to be pulling in their directions. And it's a tug-of-war game all day long with these muscles. It's a tug-of-war game. And so if you take out this 1 point of energy, then the rest win. And then the remainder are 3. So the other 4 muscles plus some of your pupil and your upper eyelid go into the 3rd cranial nerve. So if you lose your 3rd cranial nerve, the other 2 are this guy and this guy. Well, if the lateral rectus pulls your eye out and the superior oblique pulls your eye down and out, then that person who has a 3rd cranial nerve, a full 3rd cranial nerve, their eyelids not going to work well, and their pupil won't work well. It'll be bigger, and their eye will be down and out. So the diabetic who comes in with their eyes down and out, you kind of know they have a 3rd cranial nerve. But like everything else, You don't have to have all of it gone. You can have part of it gone, and that's a whole nother story about all these specifics about parts. So what we're doing all day long is we're asking people, we want to find out, do your motilities work? Can you move up, down, left, and right, and everything's good to go? So, what we'll do is we're going to have people look up, down, left, and right, and depending upon your perspective, and decide what's going on there. So we have couple ways to do this. You can just sit here and make a big box. And so imagine you're the patient there, and we'll have you go look all the way to one side. And if you're the patient, I'm going to have you look to your right and look to your left, and then we can go make a big box up and down and left and right. Not a little one. You don't want to be right in the patient's face doing this. You want to be about 3 to 4 feet away, because if you test too closely, you can't see the problem. So be about 3 feet away. You'll have, say, look at the tip of my pen, and you'll go left, right, and you can box the whole thing off, and you'll get an idea. Oh man, you're good to go. And then you see one eye that doesn't work well, or you're paying attention. You're in the moment. You're looking at it. Your eyes are kind of darting back and forth between the two at the same time. And now the better way to do this, more specific way to do this, is we want to go use the patient's face. So you have an ear and you have a shoulder. And so what we're going to do is I'm going to be looking at you, and I'm going to go across this way. So if it's you, I'm thinking about your right eye, okay? And I'm going to have you go look to your left. Well, that's going to be checking your medial rectus, because your right eye is now looking to the left, and that's going to be pulling your eye off to your left. So I'm thinking, remember we have 6 muscles. So I'm going medial rectus, and we're working on your right eye, and both eyes are working at the same time. And you can, kind of, when you get good at this, you're just going to be doing it once, and you'll figure it out. But medial rectus, lateral rectus, then I'm going to go up to your ear, and I'm going to go up and down. I'm checking 2 muscles there. I'm going to go to your right shoulder, and I'm going to go up and down. Then I'm going to cross the midline. I'm going to go to your ear again, up and down, and over to your shoulder, up and down. And so what we're doing is, in all these 4 little up and downs that we've done in ears and shoulders, we've checked the other muscles. So the laterals, we've done right lateral, left medial rectus. Over here, we've done right medial, left lateral. And then at the ears and shoulders of each eye, we've checked the other 4 muscles, and we'll go over those with you individually so you understand that. And we're going to shoot you over to a website on here, and that will help you understand that. But basically, if we go back to this thing here, look at my hands here. In order for the superior rectus to work, I've got to get this superior rectus coming out here and isolate it and put it in its the preferred alignment. So when the eye's looking straight ahead, my eyeballs are turned in like this relative to this apex. So when I'm checking the superior rectus of the right eye, I want to have the patient look out at their ear, and we're going to go up and down. And so when we're checking this on the ear on your right side, that's what I'm thinking about, the right superior rectus. Now, we remember then the inferior rectus would be similarly on this side. And so when I'm checking your ear out on your other side, it's going to be ear. And now, in order to check the obliques, remember the obliques come like this and do that. And the best way to check that is when we're doing this one, we want to get this eye coming way over here and pulling it down here. And that would be the shoulder of your other side. So the superior oblique, you're going to be thinking, when you're looking at the right eye, the superior oblique is going to be looking down here. So the obliques, you're checking the obliques, they're the shoulder of the other side. So when you're looking down at the patient's shoulder, if they can't go down here, that means their right superior oblique is boogered up. And if they can't go up over here, that means their right inferior oblique is boogered up or doesn't work efficiently or effectively. So just go back through this again, where I'm checking you across the midline, back and forth. Then I'm having you go up and down as I'm looking, as my line is my pen, my finger, whatever I'm using to have you change your gaze. This is the recti on the same side, and this is the obliques on the opposite side. So it's opposite side, and superior goes down and inferior goes up. And so that'll make more sense as you ask me and we go through it again. But what we're doing, I'm checking the motilities. It's important. You're going to say, you're not going to make initially the diagnosis of there's a right inferior oblique problem or whatever it might be, superior oblique. You're going to make a note in the chart that says, hey doc, go take a peek at this, something's boogered up. And after we go through a number of these things and I teach you what's going on, then you'll be more efficient and effective in making the diagnosis. That's how we're checking motilities. And thank you very much. So the patient's glasses are off, and what I'm going to do in checking their motilities with the adductions, inversions, is I'm going to say, look at my fingertip or the tip of my pen. Here we'll have the tip of the pen here, and I'll go, there's a plane coming out here. I'm not going to be down here. I'm not going to be up here. I'm going to be right straight ahead, and I'm watching the right eye and left eye as I go way out here. And then I can just box this thing off, and I'm watching the smoothness of the movements. Sometimes eyes jiggle. When people get older, they have poor motilities, and that would be, I would check that motilities are full and smooth. You write down full and smooth, okay? Because they were full and they were smooth. And sometimes you'll have people who have over pursuits, and they'll have nystagmus. When people have albinism and some other things, their eyes quiver, that's nystagmus. But your job is to find normal, and then when we don't find normal, that means they're abnormal, and we'll start filling in some of those blanks. So full and smooth is the answer, or reduced, and you'll get to know what reduced is, because if my pen's out to here, but your eyes stop right there, and if I go out here and she's still looking here, they're not full. Okay, you go, well, my pen's over here, and and you'll know that. Now to do the versions, we're going to sit here and we're starting over again. We're going to go out here. I'm thinking over right medial, left lateral rectus. Over here, I'm thinking over left lateral and right medial rectus. I'm going to her shoulder, and I'm going up. And remember, the shoulder are the obliques of the opposite eye. Up here, if she couldn't do this, it's because of her inferior oblique is boogered up. And down here, if she can't go down here, and sometimes you have to grab somebody's eyelids and look down depending upon how much visible eye you have, and you'll just sit here and grab those up. And that would be the left superior oblique. I'm going to her ear, and I'm going up. That's going to be her right superior rectus, achieves that. And right inferior rectus, I'm coming over here again. Now it's the left superior rectus, the left inferior rectus. I come back to straight ahead. I go to her shoulder, and this is going to be the right inferior oblique and the left inferior oblique. And now we've checked them. So we're testing for full and smooth, and ductions, inversions, full and smooth, and you're going to start reporting those to me, and we'll go fill in the blanks otherwise. Thank you.